Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Otsuka America Pharmaceutical, Inc.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
Hi, everybody. My name is Dr. Tim Willens, and on behalf of my co-chair, Dr. Adelaide Robb, I'd like to welcome you to the program, the Triple Monoamine Interplay. What's new in ADHD treatment? So I want to start with just reminding people of some of the basics around ADHD, which is sort of prevalence. How frequent do we see kids with ADHD in adults? So we know that between the ages of 3 and 17, percent ever diagnosed is about 12%. It's higher in boys, 15, 16%, lower in girls, 8, 9%. When we look at adults, about 6% have a current ADHD diagnosis that's based on self-report. Although it's interesting, despite having a diagnosis, if you look at individuals with ADHD, only about 1 in 10 are actually treated, adults who have the disorder are treated for their condition. That's an improvement. It used to be 1 in 20. And it's also important to realize, and you're going to hear this perspective as we go through the program, which is initially, as people have more hyperactivity, impulsivity, which is predominant, as they age, there's a developmental change in ADHD. You start to see less of the hyperactivity, impulsivity, and more inattentiveness. And you also start to see more problems with attention and executive functioning. Now, in the next slide, you can see that ADHD symptoms lead to consequences. There have been a number of studies that have shown if you have the symptoms of ADHD, you have higher likelihood of having a whole lot of dysfunction across the lifespan. And conversely, if you improve those symptoms, some studies say by 30%, some say by 50%. If you reduce those, you see improvement, both short and long term, of these dysfunctions. And what are some of the things we're looking at? Consequences in children and adolescents, for example. We know that they live at school, so you see difficulties in the school setting with academic underachievement. This is also when you start to see kids getting more involved with accidents, head injuries, things like that, where it's sort of a manifestation of the hyperactivity, the impulsivity, as well as not paying attention. There's also more stress to families, more difficulties interpersonally that really continue to stay in the child's life through their lifespan, as well as self-esteem and other things. And as they get older, injuries become more significant because they're now driving. And then there's also more reckless behavior in teenagers, such as pregnancy, sexually transmitted diseases, etc. And now you can imagine if you take this into young adult years, college age, going to the military, going into the trades, and then into adulthood, more problems achieving your educational desire, getting through trade schools, more problems with your occupational undertakings in terms of getting jobs and then keeping jobs, more financial stress. People tend to make less money based on what they should make if they have untreated ADHD. You also have things such as criminal activities, depression, anxiety, co-occurring problems that some are related genetically, others develop because of untreated disorders, and then higher rates of separation, divorces, and again, that motor vehicle accident stays with them. And then finally, it's interesting when you look at charts of longevity, individuals with ADHD, particularly those who are not treated, have higher rates of issues with premature death. Now, I want you to look at the next slide where we focus on executive dysfunction and emotional dysregulation, which are not particularly the core symptoms of ADHD, but are associated with ADHD. There are evidence of some of these being, a core symptom, one symptom, but it's often these are in some places people think of these as co-occurring problems or comorbidities, and others just see them as an outpouch of ADHD. And this has been around for years. And when we think of executive dysfunction, it is involved with organization, planning, time management, when to start, when to stop, when to shift. But it also taps into emotional dysregulation. Low frustration tolerances would be the single symptom that you would see in the core ADHD symptoms. Quick to anger, but not explosive in the nature that you see with some mood or conduct symptoms, but kind of a bottle rocker, quick up, quick down. Very heightened emotional reactivities, all or none, black or white. Not able to sort of dampen one's ability to calm down. Um, and over time, sort of a rejection sensitivity. If you even go in the direction of a problem, you'll see these kids and adults will react. Now, this is all against the backdrop of the next slide, which highlights comorbidity. And we know across the lifespan, there's higher rates of co occurring psychiatric disorders, learning difficulties, and substance issues in those people with ADHD relative to those people who don't have ADHD. In this case, this is work by my colleague Jim McGough at UCLA, and it looks at women and men just to show some of the differences. But if you look at the co-occurring rates, you've got high degrees of anxiety, depression in these adults aged 18 to 64. You have high levels of substance use disorders, particularly if untreated. And then bipolar disorder is overrepresented. And the other thing I would say, we're not showing it, but if you reverse this, if you start with people with anxiety or bipolar or depression or substance use disorders in general, 1 in 5 to 1 in 4 of those individuals will have ADHD. So there's a bidirectional comorbid condition. Now, what I'd like to do is have you enjoy the next presentation, which is an animation of the pathophysiology of ADHD, really kind of focusing on a triple monoamine model.
Attention Deficit Hyperactivity Disorder, or ADHD, is a common and complex neurodevelopmental condition that begins in childhood and commonly persists straight through into adulthood. Traditionally, our understanding of ADHD has focused almost exclusively on a simple dual neurotransmitter model, dopamine and norepinephrine. Emerging clinical evidence points to a much more dynamic framework that integrates dopamine, norepinephrine, and serotonin. Part 1. The dopamine pathways, or the driver's toolkit, includes 4 critical dopamine pathways that influence motivation, focus, and impulse control. The nigrostriatal pathway, aka the roadmap, acts as the brain's internal map for movement, planning, and motivation. In an ADHD brain, this map is easily lost, making it incredibly difficult to maintain focus on repetitive or uninteresting tasks. The frontostriatal pathway, aka the brakes, functions as the brain's brake system for attention and impulses. A person with ADHD is low on brake fluid, meaning new stimuli and sudden distractions easily override their focus. The mesolimbic pathway, aka the traffic light, regulates how we process rewards. In ADHD, the green light dominates, demanding immediate rewards. The yellow light glitches, fueling impulsivity, and an ultra-sensitive red light causes intense frustration, driving a preference for small, immediate rewards over long-term goals. The mesocortical pathway, aka the travel guide, manages executive functioning. It handles planning, route shifting, and braking. Without this reliable GPS, coordinating neural traffic fails. You easily get distracted by shiny roadside attractions instead of reaching important destinations, making it hard to organize the trip, pack working memory, or smoothly navigate cognitive roadblocks. Part 2. The norepinephrine pathways, or the navigator's gear, includes two main pathways to keep the brain vigilant and alert. The cerebello-thalamocortical pathway, aka the compass, keeps a person oriented and responsive to their surroundings. Without it, a person with ADHD can miss environmental cues and make frequent errors of omission. The locus ceruleus prefrontal cortex pathway, aka the car radio, is responsible for wakefulness and alertness. Think of a clear, well-tuned radio keeping a solo driver awake and alert. For someone with ADHD, excessive background noise and static take over, fracturing their alertness and causing easy distraction. Part 3. Often overlooked, the serotonin pathways, or the emotional anchor, regulates emotional stability and patience through three pathways. The dorsal raphe cortical striatal pathway, the long line, prepares the mind and body to tolerate delays. In contrast, a person with ADHD may experience a complete inability to wait, resulting in crowding, cutting lines, or rushing ahead. The orbital frontal striatal pathway, aka the adaptability switch, allows behavior to shift smoothly when environments change. Without it, unexpected disruptions, like a flight delay, can trigger emotional dysregulation and sudden outbursts. The raphe limbic pathway, the itinerary, stabilizes mood by managing emotional nodes like the amygdala. Traveling without this itinerary leaves anxiety unchecked, creating a mental fog so overwhelming that the person may feel completely helpless and give up entirely. The next time you interact with someone who has ADHD, remember the intricate neurochemical journey they are on. After evaluating the traditional dopamine and norepinephrine bumps in the road, consider how serotonin shapes the way they feel, react, and navigate their world.
Now, I'd like to have Adelaide join me in going through. We're able to see this animation, and they commented on core issues and associated features. And Adelaide, when you're thinking of the core symptoms of ADHD, what are some of the things you're looking for?
So, so Tim, one of the things I'm always looking for is where are you in your educational or work journey? In elementary school, it's the kids who lose backpacks and winter coats. They leave their homework at home. They lose that library book. They're hopping out of their seat and talking without a raised hand. In high school, it's the person that forgets to write their homework down. They get a lot of moving violation tickets with that learner's permit before they even have a license. They may spontaneously start being physically intimate and forget that pregnancy can occur even in teenagers. When I think about adults, it's the people that have lots of job changes. The boss asks them to do something boring like all the paperwork and the timesheets, and they don't want to do it. They get upset and then they wonder why they get bad performance reviews, or they forget to pick up their ADHD medicine at the pharmacy, and then it gets put back on the shelf in a time of shortage and they can't get it for another month. And they don't call the doctor to have us help them find a good place to do it.
But not everything is the core symptoms of ADHD. In fact, there may be associated features of ADHD. And these are the things that we talked about earlier that are kind of ADHD, but kind of not. Now, I'll start maybe with some executive dysfunction. One of the symptoms that may be core is organization. And that's also sort of what I call a proxy symptom to executive dysfunction, that the secretary of the brain isn't working really well. And organization is often something that does not respond well to traditional treatments that focus on core symptoms. For example, stimulants help, but they don't really move the dial a lot in organization. So a kid or an adult may wake up with good intent, but they can't get their act started. They can't prioritize. Then knowing when to start, actually starting, motivation to start, all of this sort of falls into sort of the rubric of cognitive executive functioning. And Adelaide, you've worked with so much around emotional dysregulation. I was wondering if you can comment on what that feels like.
Well, a lot of times what it feels like is the ADHD is under good control and they're just worried something bad's going to happen all the time because in their entire academic journey they were always in trouble, always late, always behind or not understanding. And when you move into a job setting or a college setting where the pace is faster and the demands are higher, you always feel like you're not capturing everything or not learning everything. And you shut down, you withdraw, you don't participate, you don't raise your hand, and you don't ask for help. And I think that's the toughest one is that anxiety around looking not good enough means when you're struggling, you don't ask for help and you wait till the last minute because it's only that fear and adrenaline that get you through the job that you had to do that would have been easy if you had paced yourself and started at the time the job was assigned. I think also sometimes people get depressed. Things don't go well. They fail their first semester on college or go on academic probation. And then they sort of take that I'm a failure academically to mean I'm bad at everything. And they give up and they get sad and hopeless and they stop trying. They talk about no motivation. And I think those are some of the things from having untreated or undertreated ADHD that can really weigh on a person.
We talked earlier, and you've heard about sort of the developmental manifestation of ADHD. And I just want to walk through some slides pretty quickly here. You know, this slide shows the cortical thickness in typically developing youths with symptoms of ADHD relative to those who actually have ADHD. But what I want to really show you is that when you look at maturation, you see pruning and actually some thinning, cortical thinning. And this is older work by Phil Shaw from NIH. And it really shows that kids with ADHD, especially younger, start quite different from those typically developing in the blue. And over time, they approach, but they don't actually get there to where the typically developing is. And you can look at the actual thickness on the left, or you can actually look at the rate of change, the actual change of the pruning process. So there's really a developmental sort of delay initially, and then there's catch up that develops. And if you look at the next slide, you can take a look, and there's actually data to support that there's an increasing number of actual hyperactive and impulsive symptoms that are linked to slower cortical thinning. And these areas that are highlighted are just showing you in ADHD where those correlations occur. So there's actually brain changes that are linked to the development or lack of development that you see with ADHD. And this is against the backdrop in the next slide of a general delayed cortical maturation in ADHD. It's older, but it's still very important to see that. In the top, you can see the dorsal view, and the lower, the right lateral view of the brains. And you can see on the top row, ADHD, there's a delayed development compared to the next level down, which is the typically developing controls. And a lot of that delayed development is in the frontal areas of the brain and the prefrontal cortices, which are involved in many of the problem solving, inhibition, a lot of the functionality that you see or is problematic in ADHD. And in the next slide, you can then take a look and see all cortical points are a bit delayed. If you look, the green line, the typically developing, develops earlier than the blue line, which is the ADHD. And that is particularly notable in the right panel. This area I was just referring to, the prefrontal cortex, which is very involved in executive operations, as well as modification of signals for distraction, attention, focus, etc. What's interesting is there's been recent interest in what is serotonin? What is the interaction there? We know that if you just give serotonergic agents, like an SSRI, they don't treat ADHD, but there's an awful lot of emerging evidence that it treats associated areas. There's a recent paper that I found very helpful by Dr. Solomon and colleagues. It was just published in 2026 in Clinical Drug Investigations. And really, it looked at the interplay between serotonin and ADHD, made the point that serotonin regulates emotional responses and impulses. That's not new per se, but it kind of reformulates how you see it. We've known that about serotonin, the SSRIs, and other things for quite a while. But what I think most people don't appreciate is the interaction that they highlight between serotonin and dopamine and norepinephrine, that it occurs both cortically and subcortically. So diffuse neural pathways in the brain. And by that sort of level of diffusity, you see impacts on attention, behavioral control, and executive function. So it'll be interesting as you walk through the slides and the mechanisms to know what's dopamine, what's norepinephrine, and what may have serotonergic capability. So, Adelaide.
And I think that's a really great next step focus, because I think if just dopamine and norepinephrine took care of everything, we wouldn't be looking for new kinds of medication and new activity to help people, because ADHD isn't just a 9 to 5 kind of problem. And even with treatment of that focus and attention, you have other issues that come up, especially over the course of development. So, we're going to talk about some of the new and emerging ADHD medications. And it's really exciting to see some of the things that are out there for all the people we help. So, when we talk about stimulants, we've got amphetamines, which have a mechanism of action on dopamine and norepinephrine reuptake inhibitor. And the effect size of those drugs is 102 in kids and 0.79 in adults. So this is as good as, I always like to tell my fellows, an antibiotic for strep throat if you've got the right antibiotic. You give it to somebody, it should work. Same thing for methylphenidate. Again, that adult effect size is lower, and the pediatric effect size is 0.78. Let's talk about a new trimodal release formulation of dexmethylphenidate, CTX 1301. And here, what they're looking at is pediatric subjects, and it is a phase 3 double blind trial. So, this is a large trial. This is getting ready for registration. And what they see is that when you're on placebo, you get very little effect from placebo. And the 3 doses of medication are all effective, looking at a big change in the ADHD rating scale compared to placebo. Some of the non-stimulants that we've used for a number of years include clonidine, which is a centrally acting alpha-2 adrenergic receptor agonist and a pediatric effect size of 0.71, guanfacine, an alpha-2 adrenergic agonist for the 2A subtype, and pediatric effect size again of 0.67. So basically similar, those two medications. And then atomoxetine, which is a selective norepinephrine reuptake inhibitor. We've got a pediatric effect size of 0.56 and an adult one of 0.45. So we're certainly lower than the stimulants, but these are medium effect sizes. They're not small. What about the newest non-stimulant, which is viloxazine? It's also a norepinephrine reuptake inhibitor, but it also acts as a dopamine reuptake inhibitor in the prefrontal cortex, that part of the brain that Dr. Willens and his neurodevelopment slide showed us comes online last, and a 5-HT2B antagonism. For children on functional impairment, that effect size is 0.7, and for adolescents, it's 0.33. This is a look in adults with ADHD. And these are adults that have elevated scores either on self-rating, like the PHQ-9, which is a self-rating score for depression, or clinician rated, the MADRS, the Montgomery-Åsberg Depression Rating Scale. And for anxiety, the GAD-7, General Anxiety 7, self-rated again, or the Hamilton Anxiety Scale. And they're looking at using viloxazine for the ADHD, but also saying, does it have an impact on your level, self-reported or clinician rated, of anxiety and depression? And what they found was the scores all dropped from baseline out to the end of the study. So if you've got that person that we already talked about who's got some of that emotionality, that anxiety or depressive symptoms, you may want to think about fluoxetine as an option. Side effects are not particularly burdensome and include things like sleepiness and dry mouth and decreased appetite. So now we're going to look at some of the emerging therapies, new category, if you will. So the first one we're going to talk about is centanafidine, which has three modes of action: dopamine, norepinephrine, and serotonin reuptake inhibitor. We've seen the norepinephrine only, we've seen the dopamine, we've seen the alpha agonist. We're going to look at that serotonin. And this is an adult study, and I just want to remind everybody this medication has been studied extensively. It is not currently FDA approved. So this is looking at adults, and we're just looking at the ADHD rating scales compared to placebo. And you can see on the top line that placebo did not change dramatically after 14 days, but by day 14 and continuing all the way out to day 42, you're seeing a reduction in the ADHD symptoms on the different dosing strengths, the 200 and the 400 of centanafidine. This is just another trial showing the same thing. And again, here we're seeing a little bit earlier onset at the 200 and 400 milligrams. By day 14, we're already statistically significant in our reduction of ADHD symptoms. You see some GI stuff, dry mouth, nausea, diarrhea, constipation, upper respiratory tract infection, and some headaches, odd dreams, anxiety and depressed mood, and irritability and rash. Now we're going to switch gears and look at our teenagers with the same medication. And what we're looking at again, it is a 6-week trial. And here, what you see is there is a difference in the dosing, and it's that higher dose of 328 milligrams of centanafidine that seems to be effective in our teenagers in terms of reducing ADHD symptoms. Again, the side effects look very similar to what we saw in our adult patients. Again, sleepiness, fatigue, irritability, abdominal pain. Nasopharyngitis really just means winter cold or spring cold, but it gets reported because it happened in a trial. Here we're looking again at children. So we've gone from our adults to our teens to our elementary school, middle school age kids. These are the 6 to 12-year-olds. We're doing high and low dose. It's again about 150 people in each arm. And we're seeing a reduction on both the low dose and the high dose, although definitely a dose response curve in the blue. High dose centanafidine seems to be more effective than the lower one in reducing those ADHD rating scales. And no big difference with the pediatric and adolescent side effects. We've again got rash, a lot of GI stuff, and streptococcal pharyngitis because kids go to school and they get strep throat, but it gets reported in a clinical trial. What about executive functioning? We talked about that at the end of the slides that Tim went through. And this again is that remembering to get the sources for your paper, using the study guides so that you can pass your calculus test and all the rest of it. As part of the Connors rating scale, there are a couple of questions in that actual ADHD rating scale that target learning difficulties and executive functioning, that part that we said is harder to treat with just a stimulant. And what we're seeing here is using the high dose only of centanafidine, which we saw in the previous slides was the effective dose or the strongest dose response. We looked in both the teens and the younger children, and what we see is an improvement in executive functioning and learning issues when they went from the beginning to the end of the trial. So the kids on active medication had greater improvement in their executive functioning and learning issues than the kids on placebo, which was nice to have as part of the other ADHD information. We then wanted to ask about emotional dysregulation. We looked at some of the other adult trials, like the viloxazine one with the adults with depression and anxiety, but that volatility, that getting upset is often an issue for kids in elementary school and middle school and high school as part of their ADHD overall clinical picture. And here again, we've combined the child and adolescent graphs, if you will, to put it all on one area. And what you see is using the placebo in black and the high dose medication in blue, there's a marked difference in that emotional dysregulation as early as week 1, and that continues to be separated out to the end of the study at 6 weeks. So early on, we're not only having them focus and pay attention, but that volatility, that impulsivity to blow up, if you will, or get upset or get angry and storm off or disrespect a teacher in the classroom, which gets many kids in trouble, that settles down, if you will, using this medication. We're going to now switch gears and talk about another medication that's under development, and that's solriamfetol, which again is a dopamine and norepinephrine reuptake inhibitor. So back to two mechanisms of action. And this is a very early phase 2 trial where we are taking a dose and we're comparing it in a small group against placebo. And we're looking at the adult ADHD rating scale. And here we're looking at side effects. And what we see again when we compare the two, placebo's on the top in the solid black line, and solriamfetol is on the bottom in a dotted line, is really by week 2 and then continuing out to week 6, we see a reduction in the ADHD rating scale. Side effects that we're seeing again include loss of appetite, GI upset, sleepiness, increased energy, and cardiovascular and neurologic side effects as well. We don't have any further data, so this is just the first peek against a placebo in adults. Another emerging therapy is Mazendal, which has dopamine, norepinephrine, serotonin inhibition, orexin receptor partial agonism of serotonin 5-HT1A agonist, and mu opioid receptor partial agonist. So a little bit of everything, if you will, in the brain. Tim, what do you think about hitting that many receptors?
It reminds me of the old tricyclic class antidepressants.
Exactly. It sort of goes for everything. But when we think about it, all of those neurotransmitter systems in the brain are interrelated. And when we hit one or two, other things may change as well. So this time they went for everything. What they saw here in this open label pilot study, so remember there's no placebo, there are 24 children and 21 made it through the end of the study. And we're looking over time at symptoms. And we saw some reduction in that ADHD rating scale again, but we also saw some side effects. This is when you hit that many receptors, a side effect's got to pop up. So 45% of the kids, at least almost close to half of them, had some kind of side effect, but another 34%, so another third, had moderate side effects, and some even had up to 20% had severe side effects. Big ones were loss of appetite, sleepiness, stomach distension and pain. And in the 4 kids that had a severe decrease in appetite, most of them were during day 1. So as soon as they took it, they got pretty sick. And one came later on. So this may not be ready, if you will, for additional testing, knowing that we have a bunch of other medications that are effective or show promise in early trials and may not have this level of side effects. But I think we can have them think about it some more. There's also a double blind placebo controlled trial again. So placebo in the top and the ADHD rating scale on the bottom out to week 8, and you see a clear separation. Again, remember, we're hitting multiple receptors, and those side effects are still there. All the dry mouth, the nausea, a number of GI side effects, and again, that decreased appetite. Tim, I know we sort of breezed through everything. What do you think we need to tell them as takeaways on where we are in the stage of ADHD treatment development? I still remember, and I'm sure you do too, when Oros methylphenidate was the first long-acting methylphenidate, and kids didn't have to go to the nurse's office twice a day at school to get help. And we've come so far.
We have, and I think it's great. I think we're really starting to understand in our practitioners as well as our patients are the nuances of treatment, and that's what's exciting. That we're, I think, moving beyond just stimulants. And believe me, the stimulants are super important, and we have lots of different preparations available. But we're now looking at other sort of associated or affiliated issues with ADHD, and our treatments now are focusing more on those, and our outcome measures are looking at that. So that's where I'm excited in terms of seeing that being addressed now, as well as treatments that probably are going to work with long duration and for long periods of time.
And I think that ADHD really can be a lifelong disease, and I think stopping when school stops is not the right answer for everyone, and I think you need to continue, especially if you're an adult that came in for depression or came in for anxiety, and maybe, as you had said, a lot of them could still have ADHD. They come in because they have those emotional symptoms. They get started on those medicines and something's still not working right, even though the depression rating scale or the anxiety rating scale got better. You want to make sure you think about what else could be going on. And many people, especially our women, don't always get recognized or treated when they're younger for ADHD because they're not climbing on the furniture and trashing the classroom, if you will, or running down the hallway, and they get missed. And that illness doesn't go away, that difficulty focusing and paying attention and learning and mastering material and organizing things still impacts their lives. And looking at the big picture and being more comprehensive in your evaluations and treating everything, not just one symptom, makes a huge difference for our patients. And thank you, Medscape, and all the rest of you, and Dr. Mullins, for asking me to be part of this important discussion. Thank you for participating in this activity, and you're going to be able to find some useful tools and resources on the right hand side of this page.